Hello, all. Welcome to what we're calling Open Forum 2. I'm really excited to see all of you here and really excited for those of you who will be able to watch this video later on. Definitely, we want to jump right in because I know we've got a lot of questions to try and get through. I just want to give a little bit of background. So Michael Fratkin and I hosted an open forum earlier this year, and we invited the participants to ask all the questions they had around end-of-life care and psychedelic care. So we're here today to answer as many questions as possible. And we also need to acknowledge that there's much we don't know and there's much we're learning as we go on. I'm also very grateful for the fact that there is tremendous collective wisdom here, not just residing in the panelists. So I'm really looking forward to your comments and to your questions towards the end. I would ask, though, if you could hold your questions and refrain from using the chat for this earlier portion, and I promise we'll try to get to everybody. If we don't get to everybody today, by the way, you all will have my email if you don't already when I send out the recording. So please do continue to send your questions in. One of the things that is exciting about this field is, of course, the research. And I always give a shout out to Sunstone Therapy. So Sunil, a shout out to you. And one of the things that's really great, I think, is his recently published research, which has shown that one single dose of psilocybin after 18 months, participants reported, 64% of the participants reported a significant reduction in depression, and maybe even more extraordinary, 57% of the participants reported their depression was in remission. So, and I also know that there is at least 18 more clinical trials where people are looking to recruit or will be recruiting. And so for any of you interested in learning more about what's going on, please do go to clinicaltrials.gov. Sunil and Sunstone Therapies also have additional ones that are coming down the line. So, it's really an exciting time, I think, for this field. I will say, though, that's what's different about this panel is that everybody here has real world experience. And so probably amongst them have facilitated or prescribed or participated in thousands of sessions, whether that's ketamine or psilocybin or MDMA. So I think amongst the five panelists here, you've got a lot of expertise. So today we will cover the topics that had come up before and loosely can be fit into sort of health considerations and contraindications, challenging experiences. I definitely would like to cover the spiritual aspects as well as the our culture, the impact on our culture. So as I said, we will leave time at the end so you can ask your questions. And we also will focus today basically on ketamine because it's legal, psilocybin, the most widely researched in this specific field, and MDMA because it is going to be approved by the FDA next year. So looking forward to that. And we'll also touch on 5-MeO-DMT as it's used in the context of end of life, which reminds me, when I know I say end of life, I'm pretty much talking about anyone who has been diagnosed with a terminal illness. So we're talking about early on in the diagnosis, and we will talk about this all the way to people who are pretty close to end of life. And I know some of you have experience with that as well. So I guess what we'll go ahead and do is jump right in. For those of you that don't know me, I'm Chris Caldwell, the founder and executive director of End of Life Psychedelic Care. We are a nonprofit dedicated to educating both those on the consumer side, those with the terminal illnesses, as well as professionals, many of which those are I can't talk, of who you are. In any end-of-life related care field. So now I'd like to go around and have the panelists introduce themselves briefly. Thomas, I'll start with you.
Nice to be here. Thanks for having me. My name is Thomas Hartle. I am an 8-year stage 4 colon cancer survivor. I have had 7 different experiences with the therapeutic use of psilocybin for my end-of-life anxiety.
Thank you, Thomas. Matt, you're next up on my screen.
Hi, everybody. I'm Matt Brown. I'm a child, adolescent, and adult psychiatrist. I have a private practice in Chicago. I typically work with folks with high levels of anxiety, like OCD, and also like PTSD, that kind of stuff. In my clinical practice, I mean, I use ketamine, not super frequently. Probably about, like, I don't know, 5% of my clients might be on that. And I've been working on and off in psychedelic research and space and commentary for, I don't know, close to a decade.
Yeah, Matt is a co-founder or founder of Psychedelics and the Future of Psychiatry.
So yeah, so I started a meetup group in 2016 called Psychedelics and the Future of Psychiatry here in Chicago. To be fair, and I don't think it's updated on my LinkedIn, I've kind of stepped away from that roughly about a year ago, just because I don't know, wasn't really feeling the meetings and stuff, and we hadn't met in a while. But we were probably one of the biggest groups in the Midwest for a while. Grew to, I don't know, I think it was like close to like 1,500 members. Yeah.
Yeah. Well, you had the foresight, like you say, you've been at this for a decade. LB.
Hi there. So my real name is Laura Barry, and my friends call me LB. I work in hospice. This is my second career. Somewhere along the line, I went to seminary where I studied a lot of spiritual things, and that was done for me, not thinking that I would ever actually use my learnings out in the world. But anyway, became a Reiki master, got my master's in metaphysics, and realized that there is way more to life than just this physical experience. So thanks for having me on this panel.
Thank you. Michael.
Unmute. Hi, I'm Michael Fratkin. I would like to highlight my affinity with those of you in the room that are beginners. I am a 30-year veteran of palliative care service as a physician and a hospice medical director. But the truth is, in relationship to this work as a server of medicine, I'm new to the space. I'm a beginner. I'm a student, and fascinated. As an individual explorer of my own consciousness, I'm not so new. I have more experience with medicine work and deep dives into my personal consciousness that informs some of what I bring today. But really, most of us, many of us, are beginners in the space, and I want to savor that part of this journey for myself.
Thank you, Michael. And last but not least, Mary.
Good morning. My name is Mary Taliano, and I'm an end-of-life doula and the creator of Anamkara Academy and Sacred Journeys, which one school helps train other doulas to hold this space and gives them a little bit more information on how to apply. And then Sacred Journeys, which teaches those doulas, if they want to go into plant medicine facilitation, how to, and kind of giving them a little bit more enrichment as they go embark on serving psychedelics to the people at end of life. I've been serving psychedelics to end of life care patients for about 10 years now. And I'm definitely always a student. I liked Michael's share. I'm definitely always a student to the ones who are in front of me and constantly learning through this practice. The main medicines I work with is psilocybin, both in higher doses and in microdoses with people who are grieving and at the end of life. And I also work with MDMA, and I work with 5-MeO-DMT. And I'm just really happy to be here and to be included in such an expansive space. And thank you for having me.
Thank you, Mary. Mary, I have a favor, though. Mary, I have a favor to ask of you. For
Sure.
anybody who doesn't know what an end-of-life doula does, could you quickly just explain that?
Yeah, so we just, how do I put this? So every death is different, so every doula is different. And that's why people have such a hard time nailing down, like, what is a death doula? You know, they hear it and it's hard to kind of define. So there's some doulas who are really great with estate planning, vigil planning, kind of more the logistics. So the family can kind of just sink into the energetics of the space and not worry about the black and white work. And some doulas like me, we're into the sound healing, Reiki, IFS support, Hakomi support, grief support, and we kind of follow more of like an end of life planner for the party, of kind of what that looks like. So we're kind of just seeing the needs and shape shifting to how we can best support. And sometimes we're a bridge, we're resources for families to get the exact support that they didn't know was available to them, or sometimes we're just educators. So it's a very vast, wide net of what a death doula does, but I hope that kind of covers some of it.
Yeah, thanks, Mary. All right, let's dive right in. So the reasons why people use psychedelics towards their end of life is going to be similar to why other people use psychedelics. However, I think there's always some clear distinctions which should and could inform our approach to helping those individuals. But let's start with Thomas, because Thomas, you are, at least on the panel, as far as I know, the most experienced with psilocybin. So could you please share sort of a little bit about your background and what brought you to psilocybin and kind of and why, right? And why?
Sure. So I guess the short version of my story, because I have been around for a while now. I got stage 4 cancer back in 2016, and I was enthusiastically treating that and believed that I was doing very well with it. I did 12 rounds of chemotherapy. I did a couple of surgeries, and after my second surgery, the surgeons thought they had everything under control and go live your life and be happy. And that's really kind of what I did from 2017 until 2019, and been going for scans. Everything was coming back perfectly clear. Life is good. Everything's happy. In 2019, I started to experience some symptoms of anemia. We went in and had a scope done and found out that all of the PET scans that I'd been getting had actually missed 2 bleeding tumors on my large intestine. So, okay, we missed a couple. It happens, it's not perfect. So scheduled a 3rd surgery, and they opened me up and found that there weren't just the 2 tumors, there was actually 40 some tumors in there, and surgery no longer an option for me. And that's when I discovered that really the best diagnostic tools that medicine had to offer were not effective at telling me how in danger I really was from my cancer's progression. For me, that was really when my end of life anxiety kicked in. My surgeons had told me that because I had the tumors on my intestines, at any particular time I could have a rupture or a blockage in there, either of which would, of course, be the end of me. And so, of course, from that day forward, anytime you feel a gas cramp or a twinge of pain or anything, of course, it has to be the end happening right now. And so I found anxiety growing to the point where I was no longer really able to function very well. I had some experience with your standard antidepressants. Those made me feel very beige. So I knew that I didn't want to trade off not feeling anything for just not feeling this anxiety. So I was familiar with the work that they had done at Johns Hopkins with psilocybin for people just like me. And that's when I really started to look for that here in Canada. There, of course, in 2020 was no clinical trials. There were no clinicians who were advertising this as a service or really anything else that would give me access. But I hooked up with a group called TheraSil, who is a patient advocacy group here in Canada. And they assisted me with getting what's called a Section 56 exemption. Sorry if I'm rambling here, Christine, but I'm going fast as I can. They helped me with getting an exemption to our Controlled Substances Act, which granted me access to my first psilocybin therapy treatment in the summer of 2020. And that was really my my introduction to the life-changing difference that psychedelic assisted therapy can give. I can go into some detail on that if you like, but I don't want to rob time from everybody.
No, well, this is really, really important, and I so appreciate you sharing. I guess you remind me, Thomas and I had the good fortune of spending about 90 minutes together a week ago, and so that video I can make available to everybody because that's an incredible video. Yeah, well, we'll come back. I do want to mention though that when Thomas was approved through Health Canada, and yay Canada for being so far ahead of the USA, yeah. Then he went to Roots to Thrive. So for anybody who's interested in learning more about their program, it's a wonderful group therapy program. So Roots to Thrive in British Columbia. Yeah, thanks. Thanks, Thomas. Definitely will come back to you. LB, so as a hospice chaplain, you know, I think probably the clients you see know this about you. They bring their fears, their spiritual beliefs, their spiritual fears, their religious fears to you. So what is it that you see in terms of what your clients hope to get out of psychedelics?
So I think when someone is diagnosed with a life-threatening disease, there's this eye opener that happens, right? And the disease itself, or this kind of brush with what does my life mean? How much time do I have left? What about my family? Allows and gives permission for individuals to kind of step out of where their comfort zone is, right? It kind of pushes someone to do that. And there becomes this urgency to question one's life, to question one's beliefs. And certainly not everybody, but oftentimes there is a willingness to go deeper. And with some, there's also the thought process of, you know, well, what do I have to lose? It's, you know, this eye opener gives them permission to explore in ways that those who are filled with exaggerated busyness and distractions every day don't get the chance to do.
Yeah, thank you, LB. Mary, how about your clients?
Very similar to, and I you just said her name, but I see it on the screen as LB. But as she was sharing, yeah, you know, I serve two different, I guess, classes of people. One who's not facing diagnosis, you know, that's not in the front of their awareness. And then I serve people who that is in the front of their awareness. And that is the main difference that I see when I'm serving somebody who's not facing diagnosis. There's all the fears and anxieties, and there's like a different walking down the plank that they experience. And I've yet to experience it with somebody who is in diagnosis. They're usually just open, ready to go. They're integrating in lifetime. Things are kind of accelerating a little bit faster and deeper for them because the stakes are different for them. So that is one of the observations that I've noticed out of many. Yeah.
Yeah, one of the things you've shared before is the fact that as an individual gets closer to end of life, it's not so much the fear of what's going to happen. It's more like, bring it on. You know, yeah, what do I have to lose? Yeah, bring it. Michael, how about you and your patients?
It's super interesting for me. I think that, you know, I'm still just adapting to the idea that I, as a physician living inside of the typical healthcare delivery system with all of its magnificent dysfunction, am able to offer procedurally, in a sense, a non-ordinary experience to a vulnerable person. Having functioned within the mainstream for all these years, it still blows my mind. And it's still remarkable to me that the healthcare system, as screwed up as it is, thinks it can make room for extraordinary, mysterious, non-ordinary experiences, and that we have the expertise to manage it without tapping the hundreds, maybe thousands of years of indigenous and traditional care structures. It blows my mind that we think that the models of psychotherapy are adequate to contain the remarkable mysteriousness of each of us. So my patients, like everybody else, patients aren't really patients. They're just people, mortal people grappling with their mortality. They're just the same as they've always been. I tend to see people later in the game. That's when they think about palliative care interventions generally in our society. But people like Tom are the people I want to meet more of, because the late stages of illness are kind of a psychedelic experience themselves. They're wildly non-ordinary. There's all this organic tendency towards wholeness. And that really what's most needed then, it seems, is to make sure they've got a roof and they've got caregivers and they've got love and respect and good symptom control and all those basics. And my experience over 30 years is that those folks do a pretty good job of healing, as long as I stay out of their way and nudge them towards a higher degree of presence in their process. The folks upstream like Tom, I want to get to know a bit better. Inside the crazy healthcare system, Tom's world and the world of Tom's are really kind of tightly managed and controlled and centered around oncology practices. And the thing about oncologists is they kind of don't know anything really about this whole mysterious nature of human beings stuff. So having Tom in the room is really, really important, because I think that's where these kinds of interventions will make the biggest difference. In addition to that, even though I'm taking up too much time, like Tom did, we are the people, I think, that can benefit the most from deep personal work, medicine work well contained. Those of us that care for others in this profoundly vulnerable state, it may be even more important for us than it is for dying folk. So I'll be quiet.
Yeah, thank you. So Matt, I want to ask you a question based on either your experience or research into ketamine specifically. And that is the linkage to pain and depression is interesting. And of course, for people in palliative care, chronic pain is kind of goes hand in hand, as does depression. So either what's your experience, like I said, or your research into how ketamine can help then break that sort of link to depression by treating the chronic pain.
Well, so, I mean, you're kind of talking about a couple of different, even just straight up mechanisms of action. Ketamine, first of all. I mean, so ketamine does have some opioid-like effect, especially at lower levels. And so that can be very helpful for pain. As like you increase, you're getting more like the NMDA receptor effect, which is what is causing some of the the disorientation from the experience. But then through secondary messengers, all that kind of stuff, decreasing inflammation, then it tends to go back to, well, let's see, it's not involved in serotonin that way. But it stimulates glutamate predominantly, right? Which is a primary excitatory neurochemical. And so this is one of the things that theoretically can also be helpful for mood. It does have some level of anti-inflammatory effect, which can be helpful for that too. Then we're also further on down the road, a couple days after, we're talking about like the neurotrophic effect. So, but I guess I don't understand what your question is directly, because we can talk about like the neuropharmacology, but I don't know how interesting that might be to this crowd. Yeah, I mean, there's mechanisms for both, and it can be helpful for both.
Yeah,
So
right. Yeah, that would be a whole other discussion that we probably don't have time for. But what I know is that when people in palliative care, or not even in palliative care, but when there's chronic pain, for example, neuropathy or complex regional pain syndrome, ketamine at higher doses has been extremely effective. And they also then get the mental health effect, right? Their anxiety and depression can be decreased. So to me, it's just really important when you're looking at an individual toward end of life, you're also looking at the pain and the anxiety and the fear of dying and everything. So yeah, that's what I was thinking about. So thanks.
It might be a moment just to introduce it really quickly. The concept of total pain. This is a concept that emerged from the hospice world, from Dom Cicely Saunders. The idea that you can't really think about pain as a neurologic and somatic mechanism without wrapping your head around the whole context of that in the spiritual, psychological, emotional domain. And so ketamine's kind of interesting because it seems to be poking around in multiple domains. And it's hard to talk about just pain, especially in the context of impending mortality.
And not to mention the fact that, we're talking about ketamine, but just like the whole concept of pain, how you're looking at the situation. Of course, more and more evidence is supporting that other psychedelics too, that might not have any effect on, say, opioid receptors like ketamine, can very much help with pain.
Yeah, thank you. So let's go back to the spiritual aspect that we know is so important, whether it's the glimpse of the divine or glimpse of consciousness, feeling of unity, right? So Thomas, yes, we're going to start with you again, because you've told some wonderful stories, and the one I'm going to ask you about is your consciousness and cancer. So if you could please share that story, I'd love it.
Yeah, for sure. It was in my one of my sessions with the Roots to Thrive group. What I experience when I'm on psilocybin is different from what I had expected psilocybin to be. I hear people talking about, meeting dead relatives or other entities and things like that, and I've never really experienced that personally myself. For me, with the music and the space that I'm in, I experience different universes, and some of those are focused on particular emotions and different states. This one particular session that I had, I have really come to believe that I was experiencing consciousness from the perspective of my cancer itself. And the reason why I go there is because I feel like my consciousness is tied to my genetics. And I'm a firm believer in this idea of epigenetics and our genetics carrying our memory and things too, from our past and to our children. And so I really feel that my genetics hook into who I am. And this conscious experience for me was almost me. It was me, but not quite. And it made sense to me because my cancer is close. It's almost me, but it's a little different. And I had this sense of separation and loneliness. I had a little bit of a conversation with it at that time. And the perspective that I got from the cancer was really different from what I expected it to be. We always think about cancer as something that we're fighting or battling and some adversary that we're against. But the message that I really got was, do you think I really want to be here? For me, the cancer wasn't something that's invading me. My cancer is something that has become separated from me and would very much like to be a part of the whole, but it doesn't know how. And so I'm no longer fighting my cancer, because I realized that when you're having a battle against yourself, it's impossible to win. The best that we can do is try to embrace what is different and try to welcome that into ourselves, because it's still me.
Yeah.
So rather than trying to fight a battle that I can't win, these days I'm trying to find a place of acceptance where I can embrace the experience of having cancer and what that journey means. There are lessons that I have learned from it. Cancer sucks, but if I never had it, there are things that I never would have learned, and that's important too.
I think, we could listen to you all day. So share the iron filings story, because I just love that story.
For sure. The last time I was mentioning that from my perspective, I sort of tend towards this idea of panpsychism. So consciousness as an essential element of the fundamental nature of the universe. And my views on that are a little different from some of the standards. I don't believe that my consciousness is made of little bits of the consciousness that makes up the universe. I believe that different elements of the universe have a conscious experience, but they don't necessarily have a form and a function as just individual elements. So the elements that make up my body have a consciousness, but that is not necessarily me. The same way that you can have a bucket full of iron filings. The bucket of iron filings, it probably has some sort of a conscious experience, but I have no idea what that could be. But if you take those iron filings and you were to melt those down, you can turn them into a tuning fork, in the same way that the different elements of the universe, stardust, create my body. It has a form, it has a function. Now, if you were to take that tuning fork and you strike it on a table, it now produces this energetic tone. There is an energy that it has produced that is out into the universe. That tone, to me, would represent my consciousness. So my consciousness is not dependent on this body to exist any more than the tone produced by a tuning fork is dependent on the tuning fork to exist once created. And so for me, the idea of life after death, life continuing without this physical body, makes a lot more sense in that aspect, because my consciousness is an energetic piece of the universe that doesn't depend on the physical reality to exist.
Promise. Thank you. LB, do you have any stories you could share about your clients in terms of how they came to terms with their death and dying, if universal consciousness or the sense of unity played a part?
Yes. So first of all, thank you, Tom. That was just, wow. We could probably end right there. So I just want to be clear that while I work in hospice, that my clients don't come from the hospice organization with which I'm affiliated. That since it is still somewhat underground, it is by word of mouth. And folks at end of life that I've had experience with are true seekers. there is a desire to know more, to get to where and what Tom has been explaining in terms of that they are this consciousness having a human experience, or, C.S. Lewis said a soul having this human experience, right? We're not a body having a spiritual experience. We are a spirit having this human experience. And you got there. That is beautiful. And when my seekers get to that place, it really is a shift for them, because what I have found that is common with folks with end of life or with significant grief over having watched the end of life process with a loved one is that the wisdom is already within us, that they don't need to look outside for any kind of understanding, that it really is within us. And in general, in North America, we're taught to look outward to get answers versus going inward. And it is sometimes that quietness or that permission, and the psychedelics help to peel away, whether it's a cloak of fear or what needs to be let go of, so that we get to look at things differently, which in A Course in Miracles is considered a miracle when you have that shift in perception. And psychedelics allow us to experience the miracle of our true nature. So those are the common things that I see experienced with my seekers.
Yeah, thank you, LB. Mary, I bet you have some great stories too.
I do. And the one that kind of filtered to the top when Michael was speaking, and it was kind of the theme around end of life and our understanding of pain. So I had this beautiful client at the end of life. She lived a really incredible, wonderful life. And her experience with psychedelics was in the 70s, and then that got put on pause. And then she just created her dream world with her gardening and her connection with her beloved, and never really revisited the psychedelics piece. And so when I came in, a lot of our intake sessions, really diving into her intentions and me getting to understand what medicines would work best with her, and all of that process, her main theme was that there was pain and suffering attached to the separation of her body. And that was taking up a lot of bandwidth. And I think it's probably what kept her up at night in insomnia, was just, what is it going to feel like to separate? No idea. And that part was becoming the growing piece of her worry. And so I was serving her low doses of 5-MeO. That's how I serve people at the end of life. When all the boxes are checked, we go very low and slow. And we have little breaks in between. And I was giving her a low dose of 5 of the isolated alkaloid. And she went into the process and she closed her eyes and she was like, and there was like a lot of like that somatic, you know what I'm talking about, breath got more vocal, and she was definitely sinking into this place, and she kept repeating, separating, separate, oof. And she was working through this word. And so I'm just holding the space, and she comes out of that pocket, and usually we have a little bit of a talking session there, and she gets to decide, or my clients get to decide if they want to go deeper. And so in this in-between place where she had now, the medicine had fully arced and she was in a place to communicate and open, I just asked her, what was, you kept repeating the word separating. What, can you tell me a little bit about what you were experiencing in that time? And she's like, yeah, it was beautiful. It was just, there was no me, and I was floating. And she starts describing this place she went to, and I just let her get really descriptive with it. And then my next question was, and I leaned in and I said, did it hurt? And I watched a sparkle. Like, I don't know if when you see people at the end of the life, their eyes just get that diamondy shape, color of essence, and her eyes sparkled, and she goes, no. And she just rewrote her contract with that in that moment. There was nothing that I could have told her before that experience. Everything's a bumper sticker. It's not going to hurt to be separated. I promise you can do this. I've seen hundreds of people die. You got this. Like that, no matter what I said in that would not have affected her as deeply as her understanding and embodying what it felt like. And psychedelics gave her a chance to rewire her relationship with separation. And 4 days later, she transitioned on the first rain of Los Angeles, and it was beautiful, absolutely beautiful.
Oh, thank you, Mary. So, Michael, in your work with ketamine, which generally speaking may not offer as much unity consciousness, you know, what's been the experience of some of your clients, your patients?
Generally, great impact on the ability to establish pain control. Pretty darn good impact on kind of their baseline set, the sort of the amount of weight drawing them downward into depression or stringing them up towards anxiety, more sort of balance and mood and responsiveness with less reactivity, irritability, aggravation, yada, 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 better maybe functioning. But I actually think ketamine's super interesting phenomenologically. It's so many different drugs depending on the dose and the person that you're giving it to, that we often talk about ketamine's great for this or ketamine's bad for that or whatever. But the even within the range of the sort of generally psychedelic dosages between 0.5 and or 0.7, 1.2 milligrams, the experiences are really diverse. And some people bring forth a ton of sensory, emotional, trauma-informed content, and they can just get in there and roll up their sleeves and work it through. Whereas other people just get pointed in that same direction that 5-MeO-DMT, as described by Mary, sort of do. It sort of lives in this unique place in a kind of in the shelf of available medicines, and it is a bit mysterious. So I think that it has all kinds of hidden capacities. It's just hard to know who to match it to and when. And because the whole apparatus is so expensive and unfunded and all the rest of it, it's really hard to really know, really to gain a ton of experience. It's not like people are lined up with their checkbooks outside of our little ketamine assisted psychotherapy center. We're working on ways to create access and to provide funding for people. But it's hard for me to gather a lot of experience. It's hard for Phil Wolfson in the Bay Area to gather 28 people to study in a more formal and robust center. There's really no compelling economic interest in developing large and substantial, high-powered clinical trials with ketamine. There's people that are doing it. UCSF and in collaboration with USC, I think, is working on one. Phil Wolfson's working on one, but they're going to be little itsy bitsy few dozen subjects. So it's going to be actually based on community-based communication platforms that are going to allow us to learn from each other through case narratives and discussions like this. So there's that.
Yeah. Well, then speaking of that, you recently facilitated a ketamine session with a gentleman with ALS, who was actually, maybe unbeknownst to you, close to passing. So what did you think he gained from the session? Because you only were able to do one session with him, right? One ketamine session. So oh, you did two. Okay. So yeah. So what did he get from it in terms of his death and dying?
He got blown into a physical projection of full ability. He experienced a lot of running and flying and dancing some of which I could see a little bit in his floppy little disabled physical form while he was going through the experience. Lots of joy and sort of freedom from the suffocating constraints of a body that was not wanting to move anymore. He'd been sitting with medical aid and dying medicines on the shelf. We talked a lot about that in preparation, about what that meant to him. They'd been sitting there for 6 months. He didn't really know how to think about it. He was glad that they were there, but he didn't know what he was going to do with them. And he knew that he didn't want to have mechanical ventilation should his ability to manage his own breathing. He didn't want to have a feeding tube if he stopped being able to swallow and eat. But that little set of medicines on the shelf there was talking to him. I think he was really dancing at the edge of the abyss, sort of dangling his legs over the cliff. And so he hadn't had an experience of spaciousness and peace for really some time. And it, like Mary's person, there was a remote kind of memory for some pretty extensive psychedelic use in that fellow. And it sort of tapped that whole kind of expansive memory for him too. So he dropped right into an appreciation of the space and just the experience. Had we kept going further, we might have gone other places and stuff, but the physicality and freedom and liberation from the physical constraints of the ALS were the biggest things that he talked about.
Yeah.
Thomas, what do you got,
Yeah,
Tom?
Thomas.
Just wanted to add my perspective on that particular one. So for me, I always say that the idea of death and dying is very academic for me. You read about it in books, you can watch videos on near-death experiences, and you hear other people's perspectives and stories on what they think it's going to be like. And for me, I always talk about that taste of chocolate thing. So for me, like the idea of death and dying, okay, it's something I've read about, but what is it, right? And you can talk about the taste of chocolate, you can describe the way it melts in your mouth, the flavor, things like that. But for me, psychedelics presented me with my taste of chocolate. It provided me with a way to experience consciousness in a way that had nothing whatsoever to do with this physical body or this reality or my family or wife or children or any part of this life. And the experience of a continuation of consciousness that didn't rely on this reality was, for me, probably the most comforting thing I could have. So when you're talking about what does a psychedelic give to somebody in terms of comfort, it is what I feel is a glimpse at what life after life can be. And a realization, like you said, Mary, that the only place that pain and suffering really exists, it's here. So giving everybody else that taste of chocolate, I think, is something that would be comforting to anybody who is reaching the end like I am.
Yeah.
And don't you think also that the beauty of that is you now have a conviction of what that taste is? And no matter what anybody says or does outside of you, it's not going to change that experience, right? And that's, I think, the beauty of psychedelics, that whether it's end of life or not end of life, is that you get that wisdom, that experiential wisdom that just can't be taken away.
I now know what consciousness is without Thomas. It still exists. It's still an experience. It's still good, but it doesn't rely on just being Thomas. I'm not just Thomas.
Hmm.
You may be chocolate.
I could be
maybe
chocolate.
Yeah.
Chocolate would be great.
So one of the other big areas of questions surrounded health considerations. And I think for the most part, health considerations are not dissimilar for this population. There's additional ones, but there's some really basic ones. So Matt, I don't know if you can briefly describe those health considerations and absolute versus relative contraindications that we all should be aware of when we're looking at helping people.
Sure. I mean, so by and large, there's not a lot. I mean, the biggest one is probably really uncontrolled hypertension. Just because a lot of the psychedelic agents, and especially also including ketamine, like they can spike your blood pressure, and if your blood pressure is already high, then you can have a stroke, and that would be really bad. So that's a little bit obvious. Other things like uncontrolled asthma is also probably, well, I say it is indeed a contraindication, just because sometimes the activating effect, and then also just sometimes just the profound effect can be intimidating for someone. And also if you're kind of like shocked and if you have asthma, you can kind of go into an asthmatic attack, and that can be bad. Let's see, other things that, well, I mean, as far as like absolute contraindications, probably about it, to be perfectly honest. Like relative contraindications, oftentimes, you think about stuff like, bipolar disorder, schizophrenia. They say you don't often want to give psychedelic agents to those kind of folks. Although, to be fair, there have been studies in the past, like where they have done that. And also, if you talk to somebody that has worked a lot with psychedelics with lots of different populations, they might suggest that, okay, well, no, you really can, but you just want to make sure you have a really good trained therapist to just navigate all the weirdness that could come up with that kind of a situation. Let's see, significant personality disorder folks. This is the interesting thing that psychedelics have been shown to be possibly one of the only things that can be substantially helpful for those classified as having something like borderline personality disorder. However, you want to be really cautious when working with somebody with borderline personality disorder with psychedelics, just because, well, that could go sideways for a number of reasons. But it's not like this is going to be a medical thing that happens. I mean, this is all psychological type stuff. The other things then to keep in mind with that too, and this isn't contraindication, it's more like safety and use, the environment that you use things in. I mean, Chris, you're referencing my lecture. I think over and over, I kind of repeated set and setting is really the most important thing with psychedelics. Like, that cannot be said enough. So I'll say it again. Set and setting are the most important thing with psychedelics, right? Yeah. So just so making sure the person is prepared to have the experience. And if you're trying to have a healing and profound experience, you don't want, you want to make sure there's somebody else there to kind of help you out if you need it. You're probably going to be doing this, at home or in clinical setting. You're not going to be doing it at a concert. I'm not saying there's anything wrong with doing, like, utilizing these agents in other situations, but you can have very different outcomes when you do. And so just trying to take into consideration what type of things can make for a good experience is probably really one of the most helpful things to consider.
Yeah, thank you. I mean, you reminded me, and one of the things I really appreciated about your lecture was that you don't look at things as black and white. Like a clinical trial, their list of exclusionary criteria is fairly long. But once I think you get out into the real world, and the research is starting to catch up there, I didn't get a chance to read it, but there was research published about bipolar disorder. So I'm looking forward to reading that.
I'm sorry, I'm going to interject really quickly, and I see Thomas does have his hand up, but I thought somebody might bring that up today. I wanted to point out that's bipolar disorder type 2, which just means that people become like hypomanic. They've never had a full manic episode, so it's a little bit of a different thing than, say, like a bipolar type 1. But yeah, continue.
Yeah. But the research, I think, is moving forward, and I know I heard 2 different psychologists, trained psychologists, work with borderline personality disorder patients successfully. So yeah, like your point. They have to be well trained.
One other topic on borderline personality disorder too, though, what oftentimes what is categorized as borderline personality disorder, and then also this is also the bipolar disorder. If you meet somebody that has post-traumatic stress disorder, bipolar disorder, and has been diagnosed with borderline personality disorder, I can almost promise you that 9 times out of 10, that person has struggled with some sort of childhood sexual abuse. And so, we're not, so try not to think too much about the labels. Just like really look at the person and what's going on here. And that might inform, like, do you want to work with them or not? Because somebody like with that kind of a history, they might be a much stronger candidate for psychedelic therapy versus somebody that is, well, just bipolar.
Yeah, thank you. Thomas, I'm sorry, Michael, go to Thomas first.
Actually had a question for Matt, based on personal experience. I find, Matt, that when I am close to having had one of my psilocybin therapy sessions, by being in a much better headspace, I typically can greatly reduce the amount of medications that I need to take to deal with my symptoms. So, for example, definitely need less dexamethasone for inflammation. I need less hydromorphone for dealing with pain and symptoms like that. I was wondering if that is something that you have found is typical for your practice for people who are getting into a better headspace. Do you find that that is also helpful, not just on the emotional, psychological side, but also translates into physical benefits as well?
So the most direct answer to that, I'm just thinking of one client that I have who was diagnosed with fibromyalgia. It is one of the few people that I've met that I do think probably does have struggle out with post-acute Lyme. And struggled with a lot of chronic pain and a lot of fatigue. Was doing some work with ketamine, honestly fairly low dose, because this person did not like feeling altered at all, and we kept trying to go up little bit, and anytime there was any kind of a sensation, was no. But this was very helpful at first for the pain, and then slowly over time, they were able to kind of just get out and move a little bit more and had more energy. I am still seeing this person. This person is not using ketamine any longer, but they have sustained some of the level of pain relief, plus some other behavioral stuff, and they're doing much better. And it does seem ketamine played a role there.
Yeah, Michael.
Yeah, I hope so, Tom. I don't have enough experience, but I hope that that's true. It makes sense with the way that I think about that total pain, total symptom experience. And then I know plenty of folks in the pure mental health space who've been able, through some combination of what's happening in their neurotransmitters and their dendrites and their experience and the integration psychotherapy, and all of those things together have provided an opportunity to come off of beige-inducing medications in the psychiatric domain. So yeah, I think that I want to turn my attention to people who might be considering doing psychedelics and talk about adverse reactions and contraindications for them looking in. I think that people should beware the asshole in the space. There are so many people flooding our field. There are so many people who are not positioned, mature, grounded, who have not dedicated themselves to doing their own work, who have come into the space with exaggerated senses of ego and spectacularly esoteric ways to bypass their own good work. So beware the asshole in the space and trust your discernment. Now, I've been studying human beings ever since the maybe third day of my life, when I opened my eyes and I could focus on the world around me. And the thing that I wanted to look at first were faces, because I really wanted to know what those faces meant to me, who could be trusted, and how to feel safe. And since that time, I continued to do that for now 61 years. And I know a few things that I don't even know that I know in terms of articulating that. So pay attention to your gut, how you feel, where you're drawn, and where you're repelled. There's always been a lot of bullshit around the psychedelic space, and it's about to get turned up to 11. So trust yourself, be discerning, interview the people that you might consider working with. Be careful with who you recommend to other people. And if you're serving, please do your own damn work, with medicines, with therapy, with whatever it takes, and be allergic to hubris.
Mm.
Yeah, you remind me then of talking about adverse side effects or challenging trips, and we've got some people here who perhaps have sat through those journeys, and it would be good to understand maybe what some of the things were that you did. So, Mary, yeah, what I'm sure you've got some other stories about that as well.
In reference to the challenging
Yeah.
experiences.
Yeah,
Oh,
and what you did then.
I'm their biggest cheerleader for that experience. So a lot goes into the preparation of what could be possible, right? And so kind of informing people of how different medicines work through people, and possibly if I can give them as many tips and techniques in that process beforehand, I find that to be supportive when they're there. So, for instance, telling people and informing them, hey, there's a spike in blood pressure that possibly you might feel as the 5-MeO hits the blood, hits the barriers, a spike in the blood, and it might feel like you're dying or you can't breathe. You are. Just so you know, if you get to that point, I'm right here, I'm watching your body. My assistant is a nurse. So, I create as much safety in these spaces so that when the challenging experience arises, we've got some preparation and some tools that we've already kind of pre-planted that seed ahead of time. And my tips and tools for them is just installing the Buddha soft belly technique, softening the belly. So we practice that prior to going into the medicine space, so that when I say soften their belly, they know right away how to do it. They're in there. They know. I don't have to explain it now. I give my clients 2 words. So I'm not, I'm a medicine facilitator. I'm not a shaman. So I'm not with the bells and the whistles. Pretty much my soul clients and the people that sit with me, they'll hear 2 words out of me. Unless they're wanting to then participate and have conversation and dialogue, then I'm fully in it with them. But in their process, they'll either hear me, they will hear me say 2 words, either yes or safe. And if they hear me say yes, that is me just encouraging their subconscious. I've seen a relax in the body. I've seen a shift in the breath that seems more open and receptive to the medicine. So you'll maybe hear me say yes, and that's just me validating, you're safe, keep going, you're safe, keep going. If you hear me say safe, that maybe is me noticing a tightening, a shortening of the breath, a tightening of the shoulders. Maybe you're saying, I'm scared, and you'll just hear me say safe. And so I'm just kind of planting things in the intake process to support that. And I think through how I support them prior to the ceremony kind of gives them an idea that I'm a big cheerleader for their challenging experiences. I'm a big believer in that there's something there at that edge for them. So I'm just supporting what I can from the outside so that they can fully arc that energy however they can. Maybe that's through some somatic prompts and some cheerleading on the other end. And so yeah, I guess challenging experiences, they're really common, and I think that that's what makes the healing so potent. There wasn't that risk of it being scary. What are we doing this for? And so I really recognize the edges, and I support and I truly believe that our gift as facilitators is gifting people the safe space to fully feel that challenging space.
Yeah, thanks. Elby, how about you?
Yeah, so I try to not provide more information about the possibilities within a journey than someone might be willing to hear or take in. And so it's a little bit different than what Mary does. My goal is to create a container that's going to allow spiritual healing. So that involves, trust, safety, a willingness for exploration. And I meet with these seekers several times in terms of the preparation to enter into this space. And I can see with some clients that some really lean in and some kind of lean away a little bit. And so I always encourage seekers to have some kind of a mantra during their journey. The mantra that actually, before I began my own journeys a decade ago, came from my son. And he just said, "Hey, Mom, when you're going to do this," and I did it in a sacred setting, he said, "just keep telling yourself to stay open and stay curious," right? And so I use that for myself, and my mantra has shifted to stay open, stay curious, bring it on, because I want to go deeper when I do my own journeys. And I'll share that with other seekers and have them have their own mantra. And I hear them say this mantra to themselves during the course of our time together, this space together. I encourage those on this journey to invite in and be curious, whatever it is that wants to reveal itself, for them to realize that it is a safe environment, and to be, to have this openness, this willingness to go deeper, to look deeper. I find my role in this place is to really nurture the seeds of divinity that are already within them, to nurture the seeds of consciousness that are already within them, to nurture the seeds of curiosity so that they can expand more. And while there may be challenging journeys, I too think that the ones that are challenging are the most delicious.
Yeah, Thomas, thank you, LB.
Just want to chime in from personal experience here.
Mm-hmm.
My experience, like I have been in group sessions with probably 40 or 50 different people who are just like myself. And what I have sort of taken away from that is we are here experiencing this psychedelic therapy because we are dealing with difficult things, right? And just because we have taken a psychedelic doesn't make those difficult things go away. They're still going to be there. And so this anxiety and trepidation going into the experience, it shouldn't be a surprise to anybody that it exists there. I have found from personal experience that courage is always rewarded in these particular instances. And the encouragement to lean into the experience is really, really important. Being afraid and shying away from the scary thing. Let me just say that I believe that our minds are very good at iconifying things. So you're in the experience, you see a scary bear, the bear wants to eat you. It isn't really a bear, it's just your representation of something that's scary. And having the courage to let the bear eat you is, in effect, embracing the scary thing and making that connection between the I can't handle this with, yeah, I'm okay with this part of your mind. And I really believe that that courage to do that is what helps us get through some of these difficult experiences. And as I say, courage always rewarded in these instances. I have never had a bad, challenging experience that I did not come away feeling it was worthwhile.
Yeah. Thank you. Wow. Gosh, look at the time here. I think in the time left, perhaps we could take some questions. You know, Thomas, though, you remind me of, in a weird way, of the converse of what you had shared, and I'll say that, but please do. We'll start to take questions here. When you told me, you know, how you like to time your psilocybin journeys such that you actually reduce the distress around your chemo sessions, right? Of which Thomas has now had 86 chemo sessions. So, yeah, kudos to you. So yeah, why don't you say that real quickly? And I know there's a lot of comments in the chat, which I'm gonna just ask if you have a question, please raise your hand. So Thomas, yeah, why don't you share that story real quick?
Sure. So for me, I was mentioning to Matt that I have a reduction in my symptoms and stuff around that. Is that what you were?
Well, kind of how you like to time your psilocybin, maybe 2 to 3 days before chemo.
Yeah. So what I do find is that with my body, I have limited number of resources available. And when I'm feeling anxious and whatnot, all of my resources are really being kind of consumed by that fight or flight mechanism. And, you know, my body is full of anxiety, and all of my energy is really kind of going into spinning my wheels and going nowhere. And when I time having a psilocybin therapy session too close to when I'm scheduled for chemo, my mind is now quiet and I'm not in this agitated fight or flight state. So all the resources that normally would go to doing nothing are now sort of more centered on directed towards healing as much as I can. You know, not a cure for cancer or anything like that, but the resources that I do have available can now go towards reducing inflammation and just being calm and being present, as opposed to I'm just focusing on not dying right now. So that for me has helped a lot.
Yeah. Thank you. All right, I don't see any raised hands yet. Anybody have any questions? If you do, please raise your hand. There you go, Amy.
Hi. I had a question about if and when a patient is too sick to receive the medicine, that their physical body maybe can't handle it, or I don't know, maybe that isn't a thing. But that's a curiosity that I have, if that makes sense.
I saw that in
Yeah,
in the messages, and I had messaged you underneath that. I was like, I'll help you answer. So I'm sure there's multiple answers, but I'll say that when it comes to the decision to support somebody at the end of life with these medicines, first thing is I want to get the whole care team involved, if I can, as many people involved in these kinds of decisions. And most likely what happens in that process is they're informing me really of what they can handle and what they can't handle. So there's never really a process where I'm like, I don't think you can handle this, or like they're informing me. So, you know, can they get up and use the bathroom? How often are they sleeping? Are they able to eat food still? And I want to know all the kind of medical things about what's going on with them, because pretty much that informs me what's, you know, the next step. And if it's somebody say that checks all the boxes in the medical team, and the person's a full yes, well, now the other consideration is to kind of see, do they want to withstand an 8-hour journey? Can they integrate this process in a different kind of way? And so it could turn into microdosing. It could turn into me supporting them with, and Chris has the link for this. So Chris, if you want to include it in the email, the Casina. Casina is something I work with when somebody is unable to sit with plant medicine for all different variety of reasons, and I will use this. It's a goggle set. And so if we're fully at capacity and can't go with the medicine, there's always a way that I can bring in some sort of an experience for them. But to answer your question, they're usually informing me through all these different questions that I ask on the intake of what's possible and what's not possible.
Yeah, thanks, Mary. Michael?
I'll just jump in and just say there are people who seem just to me energetically my own level of comfort as a novice facilitator, and they seem really pretty fragile and maybe in an altered state as they approach the end of their life, that I'm just going to say, no, I don't think this is for you. But also, like, for my fellow with ALS, we had this like amazing conversation about, well, let's say you choke and aspirate during the experience and die right here in front of me on my lap here. How are we going to all handle that? And we talked about that and consented for the use for a short period of time, a little ventilator machine that he had at home, a little non-invasive ventilator. So I got his approval. We checked it, got the battery all set up. We had a little oxygen concentrator next to him. We made sure it all worked. We had a suction machine. I didn't get all that stuff. It's just stuff that he had accumulated as an ALS patient moving towards the end. But I wanted to get his specific consent on whether they were available to me, and whether they worked. And what if they didn't work to resuscitate him? Did he want me to call the ambulance? He said, no, I do not. I'm like, okay, that's going to be a little tricky for me, and there's some people around you, but I think we can live with that directive. So there are people, it would make me very nervous. I would have not liked it very much if he died during a session. But we were prepared for that, and then all the other good stuff that might have happened too. So.
Yeah, thanks, Michael. I mean, that raises so many good points there. People might die during the session, and I think, that needs to be discussed depending on where that individual is at. But you also reminded me of, in an ideal world, everybody would have an opportunity to use psychedelics at whatever stage of life. And the distinction might be folks like LB and Mary and Grateful Deb would be able to facilitate for certain journeys. And then when somebody is much more ill, I'll just say it that way, that there will be medical physicians there who can either support the facilitation or manage it. And yeah, that would be great. Alyssa, what's your question?
Yeah, thank you. Thank you to everybody, and thank you for this forum. It's been wonderful. My question has to do with dosing. I'm a psychedelic trained marriage and family therapist, and I work with ketamine. I know about dosing with ketamine, but I'm just looking into working with psilocybin, and I don't know as much about dosing there. And I know there's a whole range in terms of microdosing versus more of a heroic dose, and it depends on the person and their body size. But I'm just curious about guidelines for dosing with psilocybin.
Yeah, well, Mary, I'm going to turn that one over to you. Everybody always says in that answer, start low, go slow. But for all of us, we want to know, what does that really mean? So yeah, Mary, what do you really do?
Yeah, I mean, I think it first boils down to what is this person's intention for sitting with the medicine. Some people are really, in all of their words, asking for a neurological reset. Just really looking to kind of get to that threshold and really looking for that just whew. And then some people are approaching the medicine and really wanting to be an active participant with what's going on in their body. Where's the trauma been stored? They're telling you, like, a lot of things are very visceral for them in their intention, very somatic. And so that is the first thing that I'm listening to. And then the second thing I'm listening to is I'm asking them what their psychedelic resume is. What is their sensitivity? Not that their psychedelic resume matters, but I want to know their sensitivity, and I want to kind of know what their relationship is with surrender, regardless of medicine or not plant medicine. What is your relationship when things get hard? How do you process that through the mind, the heart, and the gut? And so that's another consideration. And so if it's somebody who's more on the sensitive side, doesn't really have too much experience with psilocybin, 1.5 1.5 every 45 minutes to an hour to kind of see where they're at and gauge them. Right? Because it's easy to go up. It's really hard to come back down. And so low and slow is where I go. And then I've worked with many people at the end of life who have particularly chosen me because they've worked with psychedelics before diagnosis, during diagnosis, and they're very well versed in their own consciousness. And so in those cases, I'm like, this is less of me and talking about the dosage and more of them telling me what they need. They already know where they're at and on their gauge. And so they're just letting me know, and then I'm supporting that space.
Yeah, LB, do you have anything to add in terms of dosing?
I mostly work with psilocybin, and I do start low. My intake form when I'm working with someone is pretty in depth, and we do review that. So I do have a history in terms of how they've played with or explored psychedelics in their past, whether recreationally or in a sacred context. And many of the same questions that were addressed previously are also ones that we discuss. It's important to have that kind of a history and knowledge. And then, and I do typically start slow and then add the bumps.
But what does that mean?
So slow for me would be 1.5, 1.5 grams, and then
1.5 grams, 1.5 grams.
Yes, yeah. 1.5 to 2, and then a bump based on how they're experiencing that about an hour later. I use a whole mushroom. I don't lemon tech or put it in a tea.
All right. Yeah. Thank you for specifying. Mary, though too.
Oh, go for it. No, so sorry. Zoom.
No, I was just going to go back to the 5-MeO-DMT. I know that wasn't the question, but what's that dosage typically?
5 milligrams of the isolated alkaloid. And I don't serve the secretion to, I started off my facilitation journey at serving the alkaloid or the secretion from the toad. And as I discovered more and learned more, and the more the toad became my teacher, it became quite clear that this wasn't going to be sustainable. And so I moved over to the isolated alkaloid, which is a completely different dosage. So just so you know, like a 5 milligram would be looking at like 20 milligrams for the secretion, but I would never serve the secretion to people at end of life because there's only 15 to 29% of the alkaloid in there, and then you're giving them all these other toxins that we don't even know what's in it, and that's not ethical at all. So I go with that. So 5 milligrams, we take a break. We see where they're at, and then maybe the second dose, depending on if the 5 milligrams they went into it, or if they were kind of like, I could go a little bit deeper, then maybe I'll make it 8 milligrams for the second round. And then I will peak and stop somewhere. It's not a black and white number, but I will buff around the number of 25 milligrams as being the threshold. Because some people will be like, more again. And so I let them go as far as that around the 25 milligrams, just to be very cautious of their capacity.
Great. Thanks.
And I wanted to add for the mushrooms too, another consideration that has been evolving in my practice with the mushrooms is if I have a client that's working on their masculine energy, and you know as the therapist how that's coming through, or they're looking for the father wound, clearing stuff up with their father, and so anything happening on the masculine side, I will tend to work with the gold caps. The gold caps have found to be really supportive for like the masculine space, and I've been playing around with people working, and right, we're all in the experiments, playing around with people that are working with the more feminine side, mother wound, the nurturing side, and all of those things on the left side, and then I'll work with the white caps. So it's been another thing that I've been playing around when I've been supporting people in microdosing and or the bigger journeys. So I just want to throw that out there because it's been kind of interesting.
Thanks.
Mhm.
Sunil. Hello, Sunil. Are you there?
Unmute. Yes,
Yes.
sorry. Hello, thank you.
Hello.
Thanks for taking my question for this beautiful discussion. I just had a question for Thomas, if he's still with us. Thank you, Thomas, for being here. I just wondered if you could share. I had two questions. Is part of your regimen that you are now continuing involving solo journeys? And since you've done group work and guided one-on-one work and all these things, and where does individual solo work fit in your wheelhouse or your healing? And then the other related question is, have you in this work developed a different relationship with psilocybin, where you might characterize it more as a sacrament or something more of a beyond the sort of medical model, because the kind of insights you were describing were deeply mystical. Yeah, thank you so much.
Yeah, actually, interestingly, I've sort of gone the other direction. My first experiences with psilocybin were all individual ones. So I began my first one in 2020 as the first Canadian to do that, and that was an individual one. And I've had another couple of individual experiences after that. Since that time, everything I've had has been in a group setting, and that has been a bit of a choice for me. Largely, I find the mentoring aspect of this to be really gratifying. So I really wish that I had a me that I could have talked to prior to actually having my first experience. I had so many questions and so many things I didn't know about the experience. And so these days, I focus on doing group work because I'm trying to help people who, like myself, had literally no experience whatsoever with psychedelics to sort of understand what the experience is about. In terms of how my relationship with psilocybin has changed over time, I think it would be impossible to have an experience with psilocybin like this and not have it be spiritual in some way. I don't believe it's possible to experience these altered states of consciousness or existence without recognizing that there is this spiritual element to us. And I find that psilocybin for me is dissolving lines. So our ego for me is something that divides me from not me, this from not that. And psilocybin is sort of gradually removing these lines for me. There's no longer mind and body for me. There's just me. There's no us and nature. There is just us. We are nature. And so I find over time, as these lines are removed, my relationship with spirituality and things is just grows more strong, and I believe more healthy for me. I hope that sort of covers what you were looking for.
Thank you. Yes, I was curious about whether you'd felt like a desire to recognize that, enshrine that relationship. Like, hey, this is you might go and drink your communion wafer, or it's people with a religious relationship that involves kind of like a recognition. Hey, government. Hey, everybody around me. This is my path to waking up. It doesn't mean proselytizing or anything like that, but I wondered if it felt like that, and a genuine notion that we consider in society as religious freedom or exercise.
I wouldn't consider myself to be religious, but the experience itself is absolutely spiritual in terms of I have a much better understanding of my place in the universe and who I am as a spiritual entity.
We are past time, and so I would say if anybody's willing to stay on for a few more, we'll take 3 more questions, but for any panelist that has to leave, I understand, and so please do. Give you going once, going twice, going 3 times. All right, Michael.
No, I was just saying goodbye to anybody who had to wisp away. But I'm
Oh,
ready to be
okay.
here for a little bit longer. This is fun.
Cool. All right. The other Michael, you have a question.
Yeah, any specific, thanks first to everybody, very much, both as a patient and as a physician. Any specific comments about the very end of life, when it's good or bad, or which might be most amenable to using?
Michael, do you want to talk to your ALS patient?
Yeah, I'm not sure, Michael, that there's really much to go on or any place to stand on this other than each individual guide taking responsibility for their role, their intuition, their attunement, their discernment, to make that call. I mean, from all the way to the end of the road with Aldous Huxley and his wife Laura, and then more in the Tom range of a person who's like fully and completely autonomous and in their life while grappling with the goddamn cancer. That's a big range of possibilities, and in it is populated, an infinite number of individual manifestations of interest. So each individual person that's coming through my practice, they may find me supportive and game to support them, and they may also hear me say, no, it's not for you and I'm not the right person for you.
I mean, at the very end.
At the very, 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 very,
very, very, very end. Yeah.
I don't think it's as necessary as it is titillating to think about giving psychedelics at the end.
Okay.
Anybody?
If I may comment on that, I do not work in end of life, but from everything that I've heard from anybody that's had a near-death experience and other folks that I have, who are working in palliative care, like psychosomatic medicine, the transition from life to death is a wholly psychedelic experience in and of itself. And so the question of, okay, what would you consider doing as far as like a psychedelic at the very, very, very end of life? I mean, like, I guess you could do anything you wanted, but why? Because like you're about to have this profound thing happen, and do you really want to play with that? I just let nature take its course there, personally.
How about with terminal agitation?
I would never personally consider inducing an non-ordinary state of consciousness as a response to an agitated state.
Thank you. That's what I was going to say. You said it for me.
It's an interesting question, though, Michael. I don't want to dismiss
the question,
because in part, maybe there is an opportunity to think about how these medicines could work for people in this. I mean, it's mysterious enough to understand their experience as dying people, and then when they're wild and disconnected, disoriented, and discombobulated, that's another order of magnitude more mystery.
It seems like it's a problem that we don't do well with medically at all or otherwise, and it seems like a lot of people suffer an awful lot at the end, in those last several days with terminal agitated states. So
it's true. It's true. And actually, I think the upstream use of psychedelics, this is just me throwing hypothesis, upstream use to manage and provide some of that equanimity that we're hearing in Tom's voice. I'm clear that people who are not caterwauling their way to the end, but actually strolling thoughtfully and mindfully towards the end of their life are much less likely to go bananas at the end. And people who are struggling and digging their heels in and avoiding the work that's on their plate within their family and structure, their family and container, those are the people that have a lot of trouble at the end with delirium and agitation. So yeah, upstream use makes a lot of sense, but it's a sort of an act of faith earlier on if they're interested.
Yeah, okay. Thank you.
Also found that when it comes to the agitation, sometimes it's not necessarily the person's journey or how they've lived their life, but sometimes it's just the medication they're reacting to the actual medication that they are being given. And so I just invite the families to have more conversations with the doctors about the medications they're taking, bringing this up as a concern, and then allowing them to take on that process. Sometimes it is the medications, and sometimes it's coupled in there with actual resistance to the process too.
Okay, thank you.
Jackie.
Hi, gosh, I know like everybody, there's just so much to be thankful for in this discussion. And so I'll be quick. Mostly I just wanted to share a few thoughts. I'll start with, I work in Northern California for Providence Health. I'm in the oncology department, and I work closely with some palliative care doctors. One of the palliative care doctors shared something with me a couple of weeks ago when I asked him about how he felt the difference between using ketamine versus morphine for pain, and sort of the happy accident he started to see with some of the emotional support that was coming through. And he mentioned that ketamine helps with doing he said a psychic reset versus, the morphine maybe is more clouding. So I just thought that was something worth sharing. And one of the things I'm trying to do in my role is bring education and awareness and discussion to the doctors, the oncologists, and other palliative care doctors. And I'm looking for further discussion with any other people who have thoughts about how to best do that. So I put my email in the chat. If there's anyone that has any things to share, wants to talk more about how to bring it, above board and try to get it to the patients. Medication interactions is a topic that I think really needs to be discussed and acknowledged between all different psychedelics and the many, many medications that people are on. And then lastly, I just wanted to say, I really like low dose ketamine for people, a psychoanalytic dose. I've seen it be really helpful. And I think that was it on my list. I had to write it down so I didn't forget, but those were just things I wanted to share. And anyone who's wanting to discuss those things more, I welcome your discussion. And thank you so much to everybody.
Thank you, Jackie. Hey, Glenn.
Great. Well, I really enjoyed this meeting, and I would love it if there was some way to have everybody's email to communicate with you later. So I'm a family doctor, and we say the family is the patient. So I'm wondering if any of you have experience simultaneously treating family members with ketamine or psilocybin so that they're experiencing having maybe a similar trip, not necessarily, but anybody have experience with that?
LB?
Yeah, I do. I had the fortune, actually, two different sets of clients. One was an end-of-life patient and her spouse, and it was psilocybin. And while the journeys are always profound, they were completely different. And it was not the person who was closer to end of life, had the end stage disease, really came around and got a lot of peace in her life in terms of decisions that she made and where things ended up, and individuals that she was estranged with. She really got to being centered and at peace. And her husband's experience was completely his and seemingly not related to hers, however, also bringing peace. And so I find that, individuals have really separate but profound experiences. Another one was with a woman at end of life. She died a couple weeks after she had her journey, and then her daughter journeyed with me several months after. And again, very different journeys, but peace and healing and profound awareness in those in that space.
Mary,
I will jump in on that as well, if you don't mind. Really quickly, I have also had experience doing psychedelics in a therapeutic setting with my wife. And I have to say, very highly recommended, because I am not the only one who is going through this end of life experience. My wife has been there through the entire experience, and she is going through everything with the helplessness of not being able to do anything. And it has brought a closeness to our relationship that I would love for other people to have access to. It's enabled us to bond in ways that we weren't really able to, and a closeness and stuff. So yeah, if it's possible to include family in on that, my personal opinion is yes, a very good idea.
Mary, did you want to add anything?
I'm sorry not to interject. I
Matt,
just want
no.
to comment that I've got to run. So thank you very much for having me. It was a pleasure meeting all of you, and take care. All the best.
Yeah, thank you, Matt. Well, I was going to check in anyway, because I had said 3 more questions and I see 2 more hands pop up. So are people okay to stay, or do you guys need to go? Want to be sensitive to your time. Michael, you got to go. Yeah. All right. Thank you. Yeah. Thank you, Michael, so much. LB or Mary or Thomas, are you okay to hang out for 2 more questions?
I was just gonna answer that question, and then I do have to hop off onto another call. But I was just gonna share. I have a couple stories, but I'll share one of them. I was a husband and a wife. They had a lot of experience before diagnosis as well with medicines, and I served my client, his older son, who is 26, and his wife. So I served the whole family, and it was absolutely incredible to witness the wife, who's clearly, like Thomas said, going through her own death at the same time. And it was beautiful for her to recognize in the space. She crawled over to him and started kissing his feet and wiping her tears on his feet. And she said, "Thank you, because I just realized I don't know who's walking who home, and I like that better." And that was incredible for me to witness that in that space, and just poof, that's the word, poof. Yeah.
Mary, thank you. Thank you so much. We'll talk soon. All right. Elizabeth, I see you had a question in the chat. Is it the one about it? How important is it for end-of-life folks to fast before taking psilocybin?
Yes.
Is that it? Okay. So while we have LB here and Thomas. So I don't, yeah. What do you guys think?
I typically ask, during the intake process, it's my recommendation that they have something very light to eat. And if that's going to be a hardship, a physical hardship on someone, then I'm not worried. I trust the medicine enough to know that it's going to do what it needs to do. And so I don't fret over that. It is my recommendation to minimize what someone consumes, but sometimes you can't control that.
Yeah, I'm fully agree with that as well. I have found in some instances where psilocybin can be a little nausea inducing. So if you eat light, you're not on something heavy, that makes that a little bit easier as well. So also, if you've got a lot of food in your stomach, it can slow the onset of the psilocybin as well. So you might prolong that process a little bit by having a lot of food in the stomach. In terms of just comfort and things like that, it's a better plan to go light.
Great, thank you. That's very helpful. And also, Thomas, I wanted to just thank you and share that I'm going to be a 10-year cancer survivor next week, and I'm thrilled about it. So.
Fantastic. I am happy to hear that.
Thanks, Elizabeth. Grateful Deb.
Hi, this has been wonderful. Love this conversation. Two things I wanted to say about ALS and guiding during that process, and something else also about terminal agitation, because I didn't only have cancer and, you know, have my husband really instrumental in my survival and recovery, but I also walked him through his experience, which was completely unexpected. And he had lots of terminal agitation, and he was a guy who was the most settled, most calm, a meditator, a yoga practitioner. So it's not so much, I liked what somebody said earlier about it really can be the meds, it really can be, there's other things that are happening. It's not a reflection on the person as an individual. It's not that they're resisting death. He knew very early on, as soon as he got his diagnosis, that he was good and he was done. And that's the part. And of course, I said to him, hey, you know, I don't think it's going to be as quick as you think, because I've sat with so many people who are dying. And that was the part that I was like, wow, I can't believe I got to do this for my husband. Believe me, that was quite the process for my own growth and my own transformation. And I wanted to say something else about with ALS or whatever else the family is experiencing. You know, there's family members that want people to keep fighting. They want them to fight. They want them to go on. They really, with ALS, people are so afraid of their choking, things like that. I worked with a client when I was very early, new to this, and she had ALS, and her family was, they were just freaked out from everything that she experienced. And you really want to have the family on board. You want to make sure that they're not working against what the patient wants. And I don't really like to say patient, because I'm not a physician, and my relationship with these people is always as a transformational guide. So and I appreciate so much of this conversation. This is why your own personal experience, you know, there'll be people that say, why should people have to have a psychedelic journey when they're studying how to be a practitioner? You don't have people that need to have cancer to be an oncologist. But you know what? You really do need to have your own personal experience, and you need to have plenty of it. And you also need to do your own internal work. And you also need to work your way up to working with someone who's dying, because the amount of reflection and just absolute stillness that's required is going to be something really really larger than anything you've ever experienced. It can go on for hours sitting with someone who's dying, and we know that it's not a really quick process. Yes, the preparation can take time, and there's lots of things to be discussed. They will confide in you things they have never told anyone. So thank you for allowing me to say that. I so appreciate you here. And of course, I wanted to, you know, naturally plug Serve Medicine, because we do provide a psychedelic, we're going to call it psychedelic ketamine. But for those of you who are living in decrimmed places, we can have a conversation apart from this. But if you want to be a sitter or you want to contribute to that, we welcome all support. And we also have a book that we're selling, and you can contribute to our book, put your story in the book. If you're a deadhead, that's how we do it. But I really, big thanks to Christine. I just love and appreciate you and this work so much, and to everyone here. So thank you.
Thank you, Deb. All right. Wow. It's been a journey now, hasn't it? I thank you all for sticking with us to the end. You will get the recording, and like I said, you'll have my email address. Please forward on any other questions you might have, and maybe we could do this again. But anyway, thank you all. Thank you, Thomas. Thank you, LB, and thank you all. Bye. Bye for now.